Hello, everyone. Welcome to today's webinar, which is the final webinar of our Summer Omics Learning Seminar Series. The series is presented by the Omics and Bioinformatics Core of the M-LEEaD Center at the University of Michigan. M-LEEaD is the Michigan Lifestage Environmental Exposures and Disease Center. In case you missed our previous events, the recordings are archived on our website, and I'll post the link to that website into the chat shortly. Before we get started, I'll just orient you to the Zoom system, although I know many of you are familiar at this point. Attendees are all muted upon entry and for the duration of the event. Please submit questions for our speaker, Dr. Wright, into the QA feature, which you will see at the bottom of your screen. You're welcome to submit questions at any time during the event. Also, this event is being recorded, and we will add it to our center website in the next few days. In the interest of time, I'd like to hand it over to Dr. Maureen Sarter, co-lead of our core.
Hello, welcome everyone to our third and final Zoom seminar of our Summer Omics Learning Seminar Series. As Katie said, the series is being hosted by the M-LEEaD Center of the University of Michigan. I'm Maureen Sarter, lead of the Omics and Bioinformatics Core of the M-LEEaD Center, and I am extremely pleased to be able to introduce Dr. Robert Wright from Mount Sinai in New York to you today. Dr. Wright should feel at home with us here today since he grew up in Melvindale, Michigan, right next to my hometown of Dearborn, Michigan. And he attended the University of Michigan Dearborn as an undergraduate and then the University of Michigan Ann Arbor for medical school. He's currently the Ethel H. Wise Chair of the Department of Environmental Medicine and Public Health at the Icahn School of Medicine at Mount Sinai. He trained in pediatrics at Northwestern University and medical toxicology, genetics, and environmental epidemiology at Harvard. He's the founder of Mount Sinai Institute for Exposomic Research and the Lautenberg Laboratory of Environmental Health Science, which specializes in biomarkers of environmental exposure and effects. His research is dedicated to studying the effects of early life environment and exposomics, which includes nutrition, social factors, toxic chemicals, and the physical environment, including air pollution, green space, etc. And he studies this on the effects of these on child health and development. He's also PI of and founder of an ongoing birth cohort study funded by the NIH called PROGRESS, which stands for Programming Research in Obesity, Growth, Environment, and Social Stress, which is based in Mexico City and is designed to address complex mixtures of chemical exposures as predictors of neurodevelopment and the role of psychosocial factors as modifiers of chemical toxicity. Bob has published over 300 research papers, most of which deal with environmental health issues, and has served on numerous national committee and advisory boards in the field of pediatric environmental health. So today he'll be speaking on exposomics and precision medicine. Everything that rises must converge. So I'm interested to hear what he means by that. So, and Bob, I have to give you an extra special thanks for presenting with us today, especially since you're taking this time out of your vacation week. So we're very grateful for that, and I'll go ahead and turn it over to you now. Thanks.
Thank you, Maureen. Can everyone hear me?
Yes.
Great. So for those of you not familiar with Mount Sinai, this is a photo of us. That tall building is part of Mount Sinai and is at 102nd Street. And our entire campus goes from 98th to 102nd Street, so 4 city blocks, and includes 5th Avenue and Madison Avenue. 5th Avenue is this avenue right across the street from Central Park, and this is Madison Avenue on the left side. So that's our entire campus. It's, as you can see, very much a vertically oriented campus. And our laboratory is in this building here, if you can see my arrow, and my office is, excuse me, in this building. So I'm going to talk today about exposomics and also the field of precision medicine, which I think have been rising in parallel. And I think as the subtitle suggests, they must converge. So this is actually the title of a Flannery O'Connor short story. For those of you who studied Southern literature from the 1950s and 60s, Flannery O'Connor was a famous author who, in this particular story, was talking about white poverty and Black poverty converging, perhaps ironically given the times. But the title that, the reason why I chose it is because I believe exposomics is rising as well as precision medicine, and I believe it's time for them to converge. So as an outline of the talk, I'm going to first talk about how we can apply exposomics to understand health and disease. I'll talk about what precision medicine is, why I think it is the future, and I will note that precision medicine is largely ignoring environmental health and exposomics, but I'm going to also make the counter argument that environmental health and exposomics has largely been ignoring precision medicine, and it's really time for the two fields to work together. Otherwise, it's time to converge. So what is precision medicine? So the National Research Council definition is this. It's the tailoring of medical treatment to patient characteristics so that we can create susceptibility classifications to disease, its prognosis, or a patient's response to treatment. And by doing so, we can individualize the interventions that we provide, maximize benefit, reduce treatment failures, and reduce side effects. Fundamentally, what it really means is understanding and applying each person's individual background and how that background influences disease progression and treatment response. And this is an important distinction from what we typically do in environmental health. Precision medicine operates in a setting where the probability of illness is 1. Prevention no longer matters to a physician because for a physician taking care of patients, particularly a subspecialist, the patient is sick. How they got there is actually less relevant to what he or she will do for that patient than how the environment currently is for that patient. So in other words, their past environment that may have gotten them there is not as important as their current environment. And we tend to focus on the past environment. So that's precision medicine. So what is exposomics? Well, it's not just chemicals. It's a study of all the health relevant environmental factors across the lifespan. And it's obviously gigantic in scope. And in fact, it's bigger than the genome. The genome is 4 billion base pairs. The exposome is nearly infinite. So part of the problem with exposomics is sort of getting a working definition and getting your head around what can and can't be measured. I prefer this definition, that it's all the health relevant environment across the lifespan, not all of the environment, just those important factors that have greatly influenced our health. And there's many of them that we can measure. And in fact, every year we get closer and closer to measuring the exposome. Because Iggy Pop grew up in Ann Arbor, I thought I would quote him. It's very hard to find an Iggy Pop quote that's actually something you can say in public. This is one. It's very important to know what not to do. In other words, you can't measure everything. So we have to understand what we can measure, and we have to focus on the things that are important. So right now, the field of precision medicine is practiced as a pharmacogenomic field. And the idea is, if we understand genetic variation to disease and treatment, then we can target therapies to the most effective drugs, improve efficacy, decrease toxicity, and target behavioral modifications, somebody's at higher risk because of their particular genetics. This way we can improve counseling and decision-making, improve patient outcomes and satisfaction. However, it really would only work if genes were the only source of variation in treatment and prognosis. And in fact, if you look at websites for precision medicine at different universities, and none of these are University of Michigan, but these are actual websites, almost all of them talk about genes causing disease and genes being used to target drugs to treat a disease. And they all have schematics that show DNA in one way or another. And almost none of them mention environment, but they all have these DNA and these pills and stratification of risk figures in them. Sometimes they're oriented horizontally, this one's oriented vertically, but it's basically the same idea. But we know that genetics is only one piece of a much, much bigger puzzle. Yet we keep focusing on the genetics and ignoring the environmental components that are clearly playing a role, not just in disease causation, but in response to treatment. And we know that genes don't cause all of complex diseases, and we've known this for a very long time. In fact, this is the cover of Science in April of 2002. And it talks about complex diseases as a puzzle, and it talks about all the different pieces that make up that puzzle. It includes genes, but it also includes behavior and nutrition and infections, chemicals, the physical environment, culture, society, and stress. And in fact, the introductory editorial is actually entitled, "It's Not Just the Genes." So despite this knowledge, it goes back almost 20 years at least, if not longer, we tend to focus almost solely on genetics. So how did we get here? So complex disease research focuses on complex diseases, and these are the diseases that drive healthcare costs in developed countries across the world. They include things like ADHD, obesity, asthma, COPD, renal failure, Parkinson's disease, Alzheimer's disease, cancer, and many other very prevalent diseases that are very difficult to prevent, in many cases very difficult to treat. We know that their etiology is a mixture of genetic and environmental risk factors. We also know that in many cases, these diseases are getting more and more prevalent. So they have higher prevalence, higher annual incidence, diseases like asthma, diseases like obesity. You know, autism is kind of controversial, whether or not it's due to increased surveillance or to actual increases, but obesity is pretty easy or pretty objectively measured, and that's clearly getting more and more common, as is asthma, and many, many other diseases and certain forms of cancer becoming more and more common. So the prevalence in those cases is indisputably rising. If it's indisputably rising, that's not genetics. Genetic main effects cannot explain rising rates of diseases that occur over a time scale of 10 to 30 years. Genetics needs multiple generations to change the prevalence of a disease. Plus, it would be counterintuitive that diseases that reduce the probability that you're going to reproduce would be selected. That's the whole basis of natural selection. So if anything, these diseases shouldn't be increasing, they should be decreasing if they are purely due to genetics. Unfortunately, the environmental components of these diseases are largely unidentified. I would argue in part because we focus a lot on genetics and we haven't yet focused on the environment. I think exposomics is going to start hopefully helping us understand the environmental causes. And I think that's because part of our language also creates barriers. We tend to think of nature versus nurture, and even in the way we talk about diseases and their causation, we do heritability estimates. Heritability estimates, claim that a particular disease is X% genes and X% environment. It ignores the probability that, ignores the fact that genetics in most cases confers risk and not causation, just as environment confers risk and not causation. If you carry the ApoE4 variant, you're not destined to get Alzheimer's disease. It's a probability. The probability is higher, yes, but it's by no means 100%, even if you live to be 100. And the levels of risk vary depending on the prevalence of the environmental factor and the prevalence of the genetic factor. And in fact, that probability is actually the probability of those two factors coming together. And that's why they are a risk and not a cause. So why don't we take a step back and think about why diseases are called genetic or environmental. So if all diseases are due to interactions between genes and environment, and I actually believe that that's true, then if the genetic polymorphism is low in prevalence in a population and the environmental factor is high in prevalence, to us, that disease is going to appear to be genetic. And conversely, if the environmental factor is very low in prevalence in a population and the genetic polymorphism is very high in prevalence, that disease is going to appear to be environmental to an outside observer. And this is a concept that's very difficult to see in people, but is actually easy to illustrate in chickens. And there really is a trait in chickens called yellow shanks. Yellow shanks is a discoloration of chicken legs with a particular genetic variant if those chickens are fed yellow corn as opposed to white corn. This is an example I once saw Ken Rothman give many years ago. The genetic component follows an autosomal dominant inheritance pattern. So imagine two farmers, Farmer Jones and Farmer Smith. They live down the road from each other. Farmer Jones has an inbred chicken flock. All of those chickens carry the variant for yellow shanks. For generations, his family has always fed their chickens white corn because yellow shanks reduces the price at market. One day the store runs out of white corn, he has to give them yellow corn. All of his chickens get yellow shanks. If you were to ask Farmer Jones what the cause of yellow shanks is, he would tell you it's yellow corn. So yellow corn is an yellow shanks is an environmental trait brought on by yellow corn. Farmer Smith, on the other hand, also has an inbred chicken flock. None of them carry the variant for yellow shanks. Yellow corn is a little bit cheaper, so those families always bought yellow corn. And then one day, a chicken gets a new mutation. And he notices that half of the offspring of that chicken also get yellow shanks. And then he draws a pedigree because he's an amateur geneticist. And in multiple generations, he sees that the pattern is that half of the offspring get yellow shanks. So from his perspective, Farmer Smith would tell you that yellow shanks is a genetic disease that follows an autosomal dominant inheritance pattern. So which is it? Is yellow shanks, because biologically it's the same disease in Farmer Jones's chicken as Farmer Smith's chicken, is it environmental or is it genetic? By the same token, if we think similar things are happening in cancer, is cancer environmental or genetic if it's due to gene-environment interactions? And even diseases that we traditionally think of as being purely genetic actually are due to gene-environment interactions. Phenylketonuria is an excellent example of this. You can actually avoid the phenotype if you avoid phenylalanine early in life. And that's even why we do genetic testing for it. And there's lots of genetic diseases for which it's actually easy to talk about what the environmental factor is. And they are also due to gene-environment interactions. And in this context, what is the heritability of chicken shanks? Is it 0%, which is what Farmer Jones is experiencing, or is it 100%, which is what Farmer Smith is experiencing? Or maybe heritability is almost always contextual. And so it's actually not a real thing. It's something that we're using to avoid measuring what is really happening environmentally, which are gene-environment interactions. Because all genes operate in variable environmental backgrounds. And there's a lot of backgrounds. Nutrition is a background. Whether somebody is obese or thin, whether they have vitamin deficiencies or mineral deficiencies, that can affect the way they metabolize drugs and also affect their risk for disease. When you're pregnant, you have huge physiologic changes which can affect drug metabolism. Geography can also play a big role. Temperature can vary by geography. Allergen prevalence can vary by geography. Altitude can actually increase your risk of stroke, because if you live at a very, very high altitude, you will tend to have higher hemoglobin. If you have higher hemoglobin, you have more red blood cells, and there's a slight increase in viscosity, so you can actually have higher risk of stroke, which has been shown. Culture plays a big role in your lifestyle and in your diet, which can also your social systems, all of which have very profound effects on your health. People are not exposed to single chemicals. They're exposed to mixtures of chemicals, and those chemicals vary by geography as well as by culture, and even things like pregnancy can actually vary the number of different types of chemicals that you're exposed to. And perhaps the most important background is health. If you are sick, it actually changes the way you metabolize drugs. A great example of this is back when I was an intern, we used to give theophylline for asthma. It's not given anymore. But when kids had asthma attacks, oftentimes it was due to influenza. Influenza could be a trigger. Turns out influenza infections actually altered the way you would metabolize theophylline, and kids who had an asthma attack due to influenza would actually get theophylline toxicity because they wouldn't be able to metabolize the drug as well if they actually had influenza as well. It also increases exposure to multiple drugs, or what is often called polypharmacy, if you're sick. So health may actually be the most important background when we talk about precision medicine, and it's something to think about as we try to integrate precision medicine and exposomics. So here's some examples. So the classic precision medicine example is this. A 53-year-old develops a deep venous thrombosis, a blood clot, in other words, in her upper leg on a trans-Pacific flight. She started on warfarin, which is a blood thinner, and she develops a GI bleed because she was given a standard dose. Turns out she has a genetic variant which makes her a slow metabolizer of warfarin. So she should have gotten a lower dose. And if they had done a genomic screen, they would have found that. And that is a classic example of how precision medicine and genomics can intersect. And it is a real thing, and this is actually something that could benefit patients. But what about this example? A 17-year-old child with autism has increases of head banging and anger outbursts. And if you were to do a genomic screen, and autism is sometimes thought to be a purely genetic disease, you would find nothing that would help you treat this patient. And this is an actual case that I had many years ago. Turned out he had lead poisoning. His blood lead was 73, which is very, very high. A couple of things were unusual about him. First, he's 17 years old. It's actually the first patient I'd ever seen that old with lead poisoning. Lead poisoning typically occurs in toddlers, 2 to 3 years of age. The difference was he had autism. Kids with autism have pica. They eat non-food substances. It turned out he was eating newspapers. Again, this was the 1990s. Nobody has newspapers anymore. But he used to eat newspapers, and the ink in the newspapers had a little bit of lead, but he was eating enough of it that he was getting lead poisoning. And his 3-year-old brother was not lead poisoned because his 3-year-old brother did not have autism and was not eating the newspapers. So his house was not the risk, which is the traditional risk factor. It was actually his autism that was the risk. And by understanding that intersection between autism and lead poisoning, we measured his blood lead because of the pica issue, and we were able to treat him, and his head banging and anger outbursts reduced. So this is an example where environment is actually changing the disease, not genomics. And an environmental screen would have potentially detected. In fact, that is how it was detected. And here's another example. A 14-year-old has gastroesophageal reflux, and a history of depression, and is treated with morphine for a fracture and develops respiratory failure. So a genome scan revealed no functional variants in phase 1 or phase 2 P450 genes or phase 2 liver enzyme genes that could affect morphine metabolism, which is something that could have explained this. Turns out GE reflux was being treated with Tagamet over the counter, and his depression was being treated with Paxil, both of which are P450 inhibitors. So they could operate, particularly when combined, as if he had a variant in the P450 system, but they were inhibiting the P450 system, and that's why he wasn't able to metabolize morphine the same way someone else would. And that's why he developed the respiratory failure. Again, a genome scan does not pick this up. A exposomic scan could have picked this up. So what are the most important backgrounds in precision medicine? Well, it's actually not genes or environment, but it's actually disease and treatment. And we need to do studies that will help physicians treat patients if we're going to operate in the precision medicine world. Right now, we're not. So why is that? Well, the medical perspective is, I need help diagnosing the patient. And environmental epidemiology, or exposomics and epidemiology, does help with this. Risk factors are kind of weighted variable. If you come in with chest pain and your history of smoking and eating a high cholesterol diet, odds are you probably have a heart attack. But in terms of treating the patient, it's not so helpful. In fact, I might ignore the study results. The fact that I smoked or eat a high cholesterol diet, I probably stop smoking and stop doing that and eat a much healthier diet. But whether you do a cardiac cath or a stent or surgery on me is completely uninfluenced by the fact that I used to smoke. And the same is true for lung cancer and smoking. Lung cancer may have been caused by my smoking, and I almost certainly will stop because now I have lung cancer. But whether or not I get surgery and what chemotherapy I get is actually irrelevant to whether or not I smoked in the past. So if we're going to work in the precision medicine world, we have to answer the right questions, because there are no right answers to the wrong questions. So what are the roadblocks? Well, medicine works at the individual level. It works with respect to diagnosis. People come to a physician if they have a problem. They're not coming to a physician, with the exception of primary care, when they don't have a problem. So there's something going on. The physician may not know what that is yet, but there is definitely a problem. So there's a need for diagnostic help, and then there's a need for treatment help. And treatment comes with side effects, and treatment can have variable outcomes. But in the public health world, which is where environmental health and exposomics typically lives, we think about research at the population level. We think about risk factors. If you get exposed, will you get sick? If I get exposed to phthalates, will I develop type 2 diabetes? But it's really about probability of illness, which is very different from the medical world in which certainty of illness exists because people don't see doctors for no reason. And in environmental health and in public health, we typically think about prevention, which is very, very important, but it's not what physicians do. And we think about susceptible populations. Is pregnancy a time of life in which you're more susceptible to environmental factors? So in summary, medicine really starts after the person is sick, and public health is more interested in what happens before the person gets sick, because public health is really interested about prevention. And outside of primary care, medicine isn't all that interested in prevention. It's not interested in why you are sick. We're more interested in how to treat the disease that you have. And it looks kind of like this. So public health tends to operate in that area of time that predates the disease. So if this x-axis is time, and this naught is when a disease appears, when that is when the phenotype becomes present. So on the right, the phenotype is present. On the left, the phenotype is not present. Public health research operates here with either prospective cohort studies or case-controlled studies that try to go back in time. And genetic studies that might use a family-based associations design are still trying to go back in time to find risk factors that might explain why somebody developed a disease. Whereas if you're talking about treatment, you're actually operating in this space to the right of that notch. You're looking at randomized controlled trials, or maybe you're doing clinical observational studies, but you're trying to understand what happens after somebody gets sick and how they respond to a treatment or how their disease progresses. So this is the area in which precision medicine needs to operate. So most precision medicine studies actually start after a disease begins, which is not the way most environmental health studies operate. And in precision medicine, you take a group of patients and then you move forward in time and you see how the disease progresses, whether they're being treated or whether they're simply being observed for their progression, if it's a disease for which there's not good treatments. So in summary, in public health, causation is really the research goal. And we look at phenotypes and subphenotypes. So, for example, we might look at Parkinson's and Parkinsonian syndromes. And that complicates our research because what causes a Parkinsonian syndrome, that is a disease that looks like Parkinson's disease, but actually is subtly different, may be different than the causes of actual Parkinson's disease. So subphenotypes may actually make it harder to do our research. In medicine, causation is less relevant. If somebody is sick, and whether they have Parkinson's or Parkinsonian disease, maybe it isn't so important. Maybe if you get exposed to lead, which is neurotoxic, you'll have similar side effects to that if you already have Parkinson's or you have Parkinsonian syndrome. So maybe these subphenotypes that we worry about in public health research aren't as important in the precision medicine research world. In public health, we're really interested in prevention. So if we're doing a case control study in particular, we have to go back in time. We want preclinical samples. We want preclinical environment so we can understand what caused the disease. In medicine, if we are to do research, we don't really have to go back in time. Really, just we want to have samples that are collected after the disease starts, and we want to follow people going forward. So it's actually much, much easier, I would argue, than doing public health causation research. In public health, we tend to counsel at the population level. However, healthy people don't listen, and any physician who's told a healthy patient that they need to stop smoking can tell you that it really is difficult to get that patient to stop smoking. On the other hand, there are patients that get heart surgery or they get lung cancer. When they're told to stop smoking, they stop smoking because sick people listen. So again, it's easier in some ways to do this research in the precision medicine world because people actually will listen to you. Very different than the public health world. Also, if you're doing research, healthy people are hard to recruit, hard to retain. They're very, very busy. There's less incentives for them to stay involved. Whereas people who have an illness, they're much more likely to sign up for a study, and they're also more likely to stay in that study long term. So retention rates tend to be better. And in public health research, we often need a control group if we're doing, for example, a case control study. And I would argue that in precision medicine research, we actually don't need controls. All we need are cohorts of people who have a disease, and we need to be able to follow them longitudinally over time and measure their environment to see how the environment affects the progression of the disease or the response to treatment. So why now? Why should we be doing what I'm going to call precision exposomics? Well, in the last 10 years, there have been exponential advances in exposure science. These include things like untargeted chemical assays, which are based on the same technology as metabolomics or high-resolution metabolomics. But we can now measure environmental chemicals as well as the metabolomes simultaneously. We're also able to create higher dimensional targeted chemical panels. These include both endogenous chemicals and exogenous chemicals. So we're able to actually do targeted, fully quantitative panels, as well as untargeted semi-quantitative assays. There are satellites circumnavigating the globe that allow us to measure air pollution, temperature, green space, light at night, and a whole host of different environmental factors in smaller and smaller grids. Some grids as small as 30 meters squared, which is how temperature can actually be measured. And even things like PM 2.5, which is one of the major components of air pollution, can be measured on scales of a single kilometer, whereas a few years ago, they were 10 kilometers squared scales. So we can actually measure the environment at a much finer resolution, both temporally and geospatially, than we ever been able to do before. And then with big data, we can mine public databases. We can mine the census data and get a sense of the socioeconomic status of where people live. We can mine medical records using natural language processing and machine learning to actually better understand the drugs that people take and their past history with respect to surgeries and injuries, so that we have a sense of that component of the exposome as well. And there are wearable devices. I would imagine most of the people in the audience probably either wearing a Fitbit, a Garmin, or an iWatch, which is a wearable device, which tells us all kinds of information, not only about our physiologic response to the environment, but where we are geospatially. I can guarantee you that Google and Apple know where we are, all of us, right now, unless you've turned off the tracking parts of their software. They know where we are right now, and they even know whether we're indoors or outdoors. So they're able to actually measure our environment at a scale that is very, very fine-grained geospatially and temporally. And this is all possible because of big data computational infrastructure, which arose because of genomics over the last 10 years. We are now capable of analyzing data on this scale. So, in summary, public health research is interested in understanding vulnerable populations, but I'm going to argue has largely ignored the role of environment in response to treatment and the effects of environment on people with a disease, which is a subtle distinction from the way most public health works. I'm not saying that we're not studying how phthalates cause type 2 diabetes. What I'm saying is we're not taking a group of people with type 2 diabetes and asking what happens to their insulin control and dose if they're exposed to phthalates. That's different. In the first example, we're thinking about phthalates as a cause of type 2 diabetes. In the second example, type 2 diabetes is the study cohort, and we're saying, how does phthalates affect the treatment? And that is a different kind of design, a different kind of study. And that is actually a precision medicine study and not a public health study. But environmental health can operate in both fields. So we need to start thinking about disease severity or disease progression. So people who have a disease, we can understand how environment affects it. Because I would argue that they're becoming the largest vulnerable population in the country. So we think about vulnerable populations such as people who live in poverty, people who are pregnant, children. Very, very important. But what about people who have illnesses and they intersect with all those other vulnerable populations? We really need to start understanding their environments and how environment is affecting their disease and their response to treatment. And there's lots of ways we can do that. We can use untargeted assays. Untargeted assays may be very important in diagnostics. Perhaps we can do case control studies of people with bulimia versus anorexia. And we can use untargeted assays to better understand whether or not they have one or the other or a mix of the two, because the diseases aren't necessarily mutually exclusive, but they can actually have some overlap. It allows us to do early diagnosis or even determine the prognosis or the cause. And then if we have patients, We can follow them longitudinally, and we can look at differences in their untargeted assays and whether or not they predict disease progression. So perhaps there are particular signatures of these untargeted assays that actually predict which patient with Parkinson's disease will have a highly rapidly progressive disease versus someone who does not. Because right now it's almost impossible to predict which patient is going to have rapidly progressive versus a stable disease and their response to L-DOPA, which is the traditional treatment for Parkinson's disease. So untargeted chemical assays can be run in cohorts of patients longitudinally, and we can get a better understanding of prognosis and response to treatment if we were to do this. We can predict risk of complications, perhaps. So maybe some patients who are more likely to get an adverse event from a drug treatment actually can be predicted based on their untargeted chemical screen. So we can predict the response to treatment or side effects. And we can even do a lot of this work without enrolling new studies. We can actually take archived samples from clinical cohorts or nested within randomized controlled trials that have already been run. Again, study design matters when applying exposomic data. We want to look at patients and we want to go forward in time. And then there's wearable devices and the Internet of Things. So as I said, most of us are probably wearing some kind of Fitbit wearable device that exchanges data through the internet and with other connected devices, downloads GPS and physiologic data directly. And if you want a low-tech version of this, there's the MyExposome bracelet, which actually, if you're wearing both a Fitbit and a MyExposome bracelet, you can look at both exposure and the physiologic response to that exposure over time that was simultaneous to when you wore the wristband. So this wristband actually is a silicone wristband that collects ambient and dermal exposures that happen to you while you're wearing it. So people typically wear it for a few days or up to a week, and it's an integrated measure of your environment over that amount of time. So wearable devices are widely employed in public health epidemiology. However, they're not so widely employed in disease cohorts. And I think that's a space that we can start to move into. And I think it's starting to happen. Certainly All of Us cohort is starting to do that. So I don't want to say that no work is being done, but I will say that in the environmental health world, the work that's been done is relatively limited. The number of disease cohorts that have worn the MyExposome bracelet is actually relatively small. But if we were to do that, we can track response to treatment, disease progression. We could look at things like activity and exposure during chemotherapy using Fitbits and other types of wearable devices like actigraphs. And if we link them with bracelets and other types of exposure wearables, we can look at whether or not exposure affects treatment response. We can look at things like heart rate variability and air pollution after coronary artery bypass. Or we can link untargeted signatures to high-risk electrophysiology phenotypes if we were to get urine or blood samples on patients who wore Fitbits. And then there's GIS. So there's a lot we can do in the GIS world. We can look at air temperature and climate. We can look at green space. We can look at pollution, air pollution. We can look at traffic patterns and noise, access to healthy foods, SES. We can even mine social media content. So you can actually look at Twitter. Twitter has geospatial data in it. And this is actually a map of all the quote unquote mean tweets in the New England area in 2015. This is actually done by one of our faculty, Itai Klug, who was able to get Twitter data and the geospatial locations and looked at particular mean words. And he plotted the distribution of mean words in the tweets in New England as a measure of the social environment. So like punk rock, Joey Ramone talked about DDT, one of the few rock songs that actually talked about DDT. So what can we do with exposomics in precision medicine? Well, we can look at wearable device data and how that affects patients, both in primary care, but also patients with the disease. We can collect address history and using satellites. Remember, satellites do go back in time. Satellites, most of the satellites that we use for PM 2.5 went up in the air around 1999 to 2000. So we have 20 years worth of data that we can potentially get on any given person. We can get occupational histories, perhaps with job exposure matrices. And if we can actually find these job exposure matrices with untargeted assays, if we take cohorts of people with particular types of jobs and actually start to measure the environmental factors of them before and after they start work. One day, I think we're going to take our cell phone into the doctor's office, and it's going to be downloaded at the front desk. And then we're going to get an untargeted chemical screen, and there's probably a genome scan that's already being logged in our electronic medical record. And then between the cell phone device, which has geospatial data, which can be linked to various types of maps about air pollution and noise and SES, they can AI or artificial intelligence in the background can generate risk scores for the physician from the exposome in terms of their neighborhood statistics, their occupation, chemicals they might be exposed to, air pollution, et cetera, and even perhaps link that with their genome in a genome by exposome analysis to give the physician a better understanding of the risks of illness that a particular person has, which is a real precision medicine vision for the world. I think it has to move beyond genomics and start thinking about gene by environment interaction or genome by exposome interaction. And there's a lot of work that still has to be done in the exposome world. And these are just some examples of exposomal precision medicine projects. For example, what if we measured phthalates in patients with cystic fibrosis to see the severity of their lung disease? So phthalates have been linked to lung disease, such as asthma. Patients with cystic fibrosis certainly have reactive airway disease. So perhaps if a patient with cystic fibrosis is exposed to phthalate, it actually worsens their lung function. That's a study that hasn't been done yet. We could look at environmental obesogens as predictors of glucose control in patients with diabetes. So either type 1 or type 2 diabetes. If we believe that obesogens affect glucose metabolism, then we should be studying people who already have problems with glucose metabolism and see how these environmental exposures affect them. Likewise, we think there are a lot of metals are neurotoxic: lead, mercury, arsenic. Perhaps they're modifying or exposures in the past or present are modifying Alzheimer's disease severity and progression. We should be looking at air quality in surgical ICUs to see whether or not the air actually has a lot of particulate matter in it that might actually be affecting the outcomes in different surgical ICUs. We should be looking at untargeted chemical assays to detect eating disorders such as anorexia or bulimia when they're only suspected rather than clinically obvious. There's all kinds of potential studies. In fact, if you think about PMI or precision medicine studies in exposomics, I would argue that the field is so open that most of the ideas are really low-hanging fruit. They're actually relatively easy to come up with what would be a novel idea. And exposomics is different. I think you've probably figured that out by now. Exposomics actually is very different than other omic sciences because it's not a assay, it's not a type of assay, unlike the Illumina 850K chip is sort of taken over epigenomics, at least with the methylation component of epigenomics. Obviously, there's other types of epigenetic marks, but and genomics is really about sequencing, and proteomics has a few different types of measurements, but they're all measuring the same sorts of things. I think more than any other field, exposomics is very, very broad. It will probably always include questionnaires. We want to know where you live so we can link it to the air pollution model. We want to know what kind of job you've had so we can figure out what your past exposures to chemicals might have been. At the same time, it is a big data field that uses GIS, uses geography to actually measure exposures to temperature and weather and air pollution and other types of environmental factors. Pictures are going to become very prominent. My daughter likes to take pictures after she cooks a meal and send them to me. So one day those pictures are going to be used, I would predict, in environmental epi research or just nutritional epi research. Also, people can take pictures of their cleaning products in their home, and that will give you a better sense of what they're exposed to when they're cleaning their home. Mobile devices are going to play a big role. So we can actually know where you are, but also integrate that with various types of geospatial models. So we can know when you go through a geospatial hazard field, what your level of exposure is and when it happened. Obviously, there will always be biomarkers such as untargeted chemical assays. So there will always be a need for urine and blood samples. And then there are big data computational needs so that we can integrate exposomics with the other omic fields, such as epigenomics, transcriptomics, genomics, proteomics, metabolomics, etc., in which exposomics is actually the top layer, or the layer in which interventions can occur. Because if you're going to affect those other omic fields, you have to start with the environment, because that's actually what's driving most of the changes in those fields over time, is environment, which is largely right now unmeasured, but we're getting closer and closer to measuring it every year. So in the future, exposomics and precision medicine will enable diagnostic tests so we can identify subpopulations with different prognosis. We can better understand the relationship between the chemical, nutritional, physical, social environment and that prognosis. We can identify optimal treatments based on one's exposome so we can better understand response variability, which might be due to environmental exposures, or the probability of side effects, or even the probability of compliance based on how your exposome interacts with the treatment and the disease. And if we do this, precision medicine programs are going to look more like this. I forget which one this is, but this was actually the only website I was able to find on precision medicine, which wasn't completely focused on genetics, but actually talked about genetics and other individual features, such as the medical history of the environment, their behaviors, patient behaviors, habits, and biomarkers to that effect, so that we can really stratify people at an individual level, because even two identical twins are going to have very different environments, and they may respond differently to a treatment because of those different environments. And once we do this, exposomics will complete the precision medicine puzzle. And that is my last slide.
Great, thank you very much, Dr. Wright, for a very fascinating talk. Just a reminder to everyone, if you have questions, please submit them to the Q&A function, and you'll see that at the bottom of your screen. Also, as a reminder, we are recording this talk and we will put it on our website following the event. Right now, I don't see any open questions, so we'll just give everyone a minute to type it in.
So while I know it usually takes the audience a couple minutes to type in their questions. So I'll start off with the question. So obviously, from your talk, measuring the exposome is much more complicated than measuring the genome, right? Which is one assay. Here you've got lots of different things, and I would say that I guess our primary care physicians are already doing a very simplified version of an exposo scan. Every time we go see the doctor, they give us a little questionnaire, about smoking history, other very basic things. So I was trying to think, like, what do you think would be, trying to add in all of this would be extremely expensive right away, right? So what do you think would be, I guess, the lowest hanging fruit? What should they be asking in those questionnaires, or what fairly inexpensive thing could they be measuring that may be most helpful?
Well, I don't really think it's going to be that expensive. I don't think it's going to be any more expensive than other precision medicine initiatives. But, obviously, we don't ask a lot, and I think part of the problem is, I would argue that the average physician has never even heard of phthalates. The average physician wouldn't know how to respond to somebody who said that they drink a lot of bottled water. Am I getting exposed to BPA? And I think it has to start with medical education. I think physicians really aren't equipped to answer that. I think physicians, there's actually some research that suggests that they're not equipped to understand genome scans. So, when Ancestry.com gives you your results and you bring it to your physician, it's almost indecipherable to him or her. And I think one of the challenges in precision medicine, whether it's a genomic related challenge or an exposomic related challenge, is actually medical education is going to have to change. And it's going to have to adapt. And I think it doesn't mean that every physician has to be an expert in all these fields, but readily available information on whether it's genomic or exposomic information needs to be available, and there need to be subspecialists trained that can deal with the more complicated issues that they're going to arise. So it's going to have to start with education. And I think
Yeah,
that's precision.
I think you actually had a good example in your talk where they missed, it was the inability to metabolize morphine, I think. And they checked for mutation that wasn't there, but they were taking two different medications that were kind of synergistically, I guess, inhibiting the P450, right?
Yes.
And if a doctor probably would have already known that they were taking those medications, and if they had just gone through that thought process, they likely could have caught that.
Yeah, possibly. I think Tagamet is over the counter, and it's a P450 inhibitor. And I think about when you talk to your physician, do you tell them about all the over-the-counter medicines you take? I think
they asked me that.
Yeah, but I think it largely gets missed. But if we measured it, it could be picked up in an untargeted screen, because pharmaceuticals tend to be at higher dose, so you're more likely to pick them up. So that's why I actually think untargeted screens can be very, very important, because it will help you pick things up that you otherwise wouldn't pick up. Because it's very difficult in a 15-minute medical visit to ask all the relevant questions. And in fact, it's getting more and more difficult as medicine becomes more commercialized and more, more corporate, to actually be able to get all this information. And information is getting bigger and bigger, and the medical visit is getting shorter and shorter. And that's a big tension that's going to be important in precision medicine, no matter what direction it takes. It is something that has to be addressed at some point, because it's just not possible to ask all the relevant questions. So that the information is going to have to be boiled down to something relatively brief that physicians can understand. And that's going to be,
that's a good point. So we do have a few questions typed in now. So one from Jonathan Kim's pretty broad question. He said, you gave me a lot of information. Can you go over again what makes exposomics different from epidemiology?
Well, genetic epidemiology is another field. I mean, epidemiology is a tool in which to study disease. What I'm talking about is more the environment, just as genetics is different than epidemiology, or genomics is different than epidemiology, exposomics is. One of the things you can consider, we can learn a lot from genomics and how to approach exposomics. So one way to think of this is the difference between candidate gene studies and genomic studies. So you miss a lot in a candidate gene study. You're really focused on genetic variants for which there's already information. And you're not thinking about those genetic variants for which have never been studied before. And the same thing is true of exposomics. When we ask about smoking, and we ask about high-fat diets, or we ask about whether you live in a house built before 1979, which puts you at higher risk for lead exposure, we're talking about those environmental factors that have been well studied that we know about. When we do untargeted screens, when we start to link geospatial information so that we can see that particular clusters of diseases or particular clusters of exposures occur in particular geospatial distributions, we're doing an exposomic study, because we're not starting with the limited candidates that we know about. We're trying to discover something that is unknown. And that's really what exposomics is compared to environmental health, is really about discovery, just as genomics is different than genetics.
So we have another question from Tess Mersha. He asks, how do you integrate biological or omics data with non-biological or exposome for complex disease? Can you talk practical experiences of integrating these types of data? There are many variables, and each may contribute directly or indirectly, or have different effect size to an outcome.
Yeah, so exposomics is the newest of the omic fields, and there's a lot of work to be done. I often make the analogy that exposomics is roughly where genomics was around 2005. So in 2005, we didn't have whole genome sequencing. If you could measure 256 SNPs, that was considered a genomic study, and we would even use the term genomics, but obviously that's nowhere near the genome. Right now in Exposomics, we can measure thousands of chemicals, but we can't measure the millions, perhaps even hundreds of millions of chemicals that we're exposed to. So, we're stuck mostly with candidate exposure types of studies. And we are also looking at technologies that are measuring simultaneously the metabolome and the exposome. And we're making, I think, some mistakes in separating them. First of all, any metabolite was once outside your body because it was once something that was outside your body that you either ingested or inhaled, and then you processed it. So it is part of the exposome. And we're measuring other chemicals and how that may affect their metabolism. So there's a lot of work that needs to be done in terms of integrating non-nutritional exposomic measures versus nutritional exposomic measures. And there's a lot of work that needs to be done in understanding how their variability predicts variability at the epigenome level, at the transcriptome level, and at all the different omic levels. So there's a lot of work that needs to be done, but most of the variation, I would argue, in transcriptomics and epigenomics is actually due to variation in the exposome that we don't know how they interact, and we're still working on measuring them. So the exposome is still got a long way to go before it measures millions of chemicals, but I think it's going to get there. There's a lot of work that's happening that's actually sort of analogous, I would argue, to microarrays. So many of you may be familiar with aptamers, which are sort of synthetic antibodies that you can generate to small molecules. And so you can start making customized, targeted, in theory, you can make customized, targeted microarrays for environmental measurements, whether they're hormones that respond to stress or whether they're chemicals that are exogenous or whether they're metabolites. And you can zero in on them much more readily than we could 3 or 4 years ago. So there's a lot of things that are happening. In fact, I would argue that the sort of high resolution mass spec that we do now may not be what we're doing in 3 to 4 years. I think there's going to be different technologies that evolve, just like genomics. The way we do genomics in 2005 is radically different than the way we do it today. And I would argue in 15 years, the way we do exposomics is going to be radically different. But it's not going to be one field. I think we're going to mine social media. I think we're going to mine satellite data. And I think we're also going to do assays repeatedly over time. And then we're going to have to set up databases that catalog all of this information, just like dbSNP catalogs the genome. We need databases that catalog this so that researchers can find this information, don't have to keep reinventing the wheel.
Yeah, thanks. So I think the next question is getting at those untargeted assays, maybe the mass spec ones that you're mentioning. He asked, how do you see the whole spectrum of environmental contaminants like PFAS, TCE, PCBs, phthalates, microcystins, and many others? How do you see them being evaluated and their impact integrated into public health, disease, and healthcare?
Yeah, it's a great question. This is work that's starting to happen with ToxCast and the comparative toxicogenomics database, that people are starting to catalog exposure to these chemicals and what their potential health effects are. And then just as genomics has gone away from looking at single SNP disease relationships to more complex relationships using more complex statistical approaches, the field of environmental health is getting using complex mixtures and different types of data analysis that actually integrates all these different exposures so that we start to understand the complex mixture that's actually occurring. And it's a little more complicated because it's time varying. So in genomics, at least when you're talking about DNA sequence, the sequence is time invariant. So, the SNP-SNP interactions in some ways are a little easier to understand, but because phenotypes don't appear at birth, we're probably measuring the relationship between these sort of complex SNP-SNP interactions and disease because of that. In environment, we're working in the same sort of area, looking at the complex mixtures. And a lot of work's actually happened. A lot of work is happening at Michigan, actually, in the statistical area of complex mixtures. So exposomics is really about measuring the environment, but there is a whole field of informatics and statistics, which is growing in parallel to try to take that data and integrate it with other omics and to understand its relationship to health. So both of those things have to happen simultaneously.
So the next question, you're very popular with questions today. The next question is, what is the implication if we find, for example, phthalates influence glucose metabolism in diabetes patients? So if we find an influence like this from the exposome, do we educate physicians to be aware of the phthalates, or at the population level, do we try to lower phthalates exposure? Or I guess, how do we react?
Well, great question. Well, one of the reasons why I'm a big proponent for studying environment in patients is because if you give a physician something they can do for a patient, you get their attention. If you're talking about a risk for somebody getting sick, they may bring it up, the person may not listen. This is sort of how smoking and heart disease works at the physician-patient level. If, on the other hand, you have a patient with diabetes who their insulin control is very poor, and they keep increasing the dose and they can't understand what's going on, and it turns out they use a lot of perfumes. Perfumes have phthalates, so they're perhaps one of the reasons why their insulin control is so bad is because they're using a lot of perfumes, and the physician can say, well, let's try not using the perfumes because they have a lot of phthalates in them and see how that affects your insulin and glucose control, and it works. Then all of a sudden medical education is going to change. So I think if we start targeting patients with some of the information we already know about how these chemicals work, then we can actually sort of subtly insert ourselves into medical education, because once there's an actionable intervention that a physician can do for a patient, it changes the dynamic enormously. And I think if we can show that there's something we can do, which we can often do with exposomics, and remember, patients are more sensitive because they have a disease, so the effects are probably a lot bigger than we're anticipating because we're so used to studying healthy people and we see these tiny effects. When you study someone who is already sick, you may see a very big effect. It may shock you how big that effect is because they're already sensitive and vulnerable. And I think that's when medical education is going to change, is when we can do something for patients. So yeah, I think that's a really important thing going forward.
Yeah, thanks. That's good. The next, we'll do two more questions and then we'll wrap up. Next one is, so you gave a lot of examples of channels to data mine information for exposomics, Fitbit, social media, maybe even grocery purchasing patterns. What sort of ethic questions or challenges do you see arising from this information? Should we be moving toward designating these things as private medical information and therefore protected under HIPAA? And what are the ramifications of that?
Oh, a lot of them are. Any geospatial analysis requires understanding where you live, and that's considered PHI, personal health information. So a lot of it already is. I think as a society, we have to start thinking and maybe having a discussion over the value of analyzing this data for health reasons versus commercial reasons. So I can tell you that Google, for reasons I'll never understand, Google and Apple know where you are right now, and they don't have to get consent. You just have to agree to download their software. And if you have an iPhone, the health app actually has a way to download your medical record with just a single click. And so your medical record will be downloaded onto Apple's cloud. So Apple will have your medical records, and they did not get consent. I'm not arguing that we should go in that direction. In fact, I think we need to get consent. What I'm concerned about is that there's a double standard where researchers are not trusted with the data that commercial entities like Apple and Google are. And perhaps we should have a public debate over whether or not that's appropriate, because Apple and Google, I guarantee you, are using that data for commercial purposes. And so I think there is a lot of problems with the way we handle health information in the public realm, where companies don't have to get consent to do basically what researchers are trying to do. And I think there needs to be a debate about that, because I would prefer we get consent. And I think we should get consent if we're going to understand, the implications of health. But we're doing it overtly with consent, and Apple and Google are doing it on much bigger numbers of people because they don't have to get consent. I'll be honest, if I was a young data scientist, I would have access to much more interesting data if I worked for Apple or Google than if I worked for a university, because Apple and Google have enormous amounts of that data. And we have to go through a lot of processes and regulations to get that data. And there is something wrong about that. And I don't believe it's wrong that we have to go through the process. I think it's wrong that Apple and Google don't have to go through the process.
Yeah, some interesting points there. Okay, last question is from Ruby Hickman. He asks, in informing treatment, would you be looking at or trying to find a small number of high effect exposures, or how would measures like untargeted assays inform treatment choice or dosage?
Well, I think it's an unknown how big the effects are going to be because there's almost no research in the area. My gut belief is there's going to be some really big effects that we were just unaware of because we never studied them. And I think they might be in areas like type 2 diabetes or type 1 diabetes or more severe diseases. I don't want to say there's been no work in this. Certainly the whole field of asthma, asthma is very much an environmental disease. There's a lot of work on how environment affects asthma, but you leave that disease and there's very little work. A really great study, which was published out of the University of Washington a couple of years ago, actually showed that patients who had lung transplants, who lived in areas of lower air pollution, had longer 5-year survival rates than patients who lived in high air pollution areas. And there's some really interesting work that I think can be done that's going to show relatively big effects. And I think we don't know what they are yet, because this is really a field that environmental health has not been particularly interested in the past. But if we're going to get into the precision medicine world, we have to get interested in it. And I suspect there are some big effects. There's probably gonna be a lot of small effects. I think you're right about that. But I also think because this is largely uncharted territory, there are probably big effects as well.
Thank you, Dr. Wright. I think that's all the time we have for today. We appreciate you taking all of those questions. And I'd just like to say to everyone who's still with us, thank you again for joining us for this wonderful webinar as part of our summer Omics learning series. And for those of you who will be joining us for the discussion, please see your email from me earlier today that will have instructions for joining. And if you have any questions, please just let me know via email. Thank you and have a great day.
Thanks, everyone.